Thank you, respected chairperson, sirs. So, just a small question to start with. How many of you have ever prescribed sulfonylurea? Raise your hand. All of them. So, I think this topic, therefore, carries very little meaning. So, we all know, we have used it. All of you have raised your hand. We have used it. We know it reduces the HbA1c. So, I'm going to talk a little bit different. I hope I'm audible. Mike? Audible, yeah. So I hope I'm going to talk a little bit different. I'm going to talk about some of the myths which is propagated, and I'm going to talk about the comparison between the sulfonylureas. Otherwise, if I just say it causes reduction of sugar, it will be very boring. So the 54-year-old hypothetical case, newly diagnosed diabetes, fasting 150, BP 300, HbA1c is 9.3. So one, will the sulfonylurea reduce the HbA1c? Next question. Oh, no. Many symposiums, many key opinion leaders have constantly said whenever a new molecule comes, it is better than sulfonylurea. Why? Sulfonylurea worsens beta cell loss. It kills beta cells. And there is some CV detrimental impact. So I will examine that. And you make up your mind what is true. So first, does it reduce the blood sugar? So we have got an advanced trial, which was an intensive glucose control trial based on gliclazide MR, and there we had more than 470 Indian patients. So 11,000 patients were in the trial, randomized to intensive arm, and the standard arm was gliclazide MR. And then they were followed up further, which is the advanced one. And if you can see here, those who had HbA1c of more than 10 at 4.3. Our patient is somewhere here, HbA1c between 9 and 10. So if you give, then there will be 2.6% drop, so which is close to the 7% that we are aiming for. So about the targeting the HbA1c, I'm going to show just this one slide. Then I'm going to deviate a little bit. So the next question is, no. It will kill off. It might reduce the HbA1c first, then the beta cell function is going to go away. You are killing. I know I've got many doctor friends of mine who come and say, don't give me sulfonylurea. I've heard it kills beta cells. So let us examine. You be the judge. So this is the common slide shown everywhere. That after initially the blood sugar comes down, then it begins to go up. This is from the UKPDS. But you notice that those who were on metformin, even then it went up. Those who were on insulin, even in those it went up. So whatever medication you give, with time the HbA1c will begin to creep up. That is the rule. Now, about the beta cell function. Not many people know this slide. So this is the beta cell function you can see here in the UKPDS, and this is for a period of 6 years. So for 6 years, this is the yellow one is the sulfonylurea. Red is conventional, and in the overweight category, blue is the metformin. Now you see here, when you give sulfonylurea, beta cell function improves. How do you measure beta cell function? How much insulin is coming out? So that goes up. That goes up here, and then it begins to drop. Now we just concentrate on this bit because it's a look, it is destroying the beta cell. But hang on, you compare with the conventional arm, that is also dropping. So at the end of 6 years, this is still better than this, the beta cell function. Even in the one which is on metformin, even there at 6 years, it is still better than this. So this finding refutes a widely held view that sulfonylurea will stress the beta cell. So that this clearly shows that with time there is a drop in the insulin level, but it is still better than the conventional arm. Now, great study. So this study, patients on metformin were randomized to 4 groups: sulfonylurea, glimepiride, sitagliptin, liraglutide, and glargine. I am 100% sure they included this. They wanted to show that the patients on glimepiride will fail. So what was the primary outcome? So you have metformin, you have divided into 4 categories. What is the primary outcome? Primary outcome is who fails first. So those who have got the shortest time to fail is the worst drug. Those who have got a longest time to fail is a good drug that preserves beta cell. Everybody expected glimepiride to fail. But the result is liraglutide was the best, followed by quite large gene, and then not that far behind is glimepiride, and that is way ahead of sitagliptin. And this is a properly done RCT for a few years. So why are we saying again and again that it destroys the beta cell if it is able to maintain it here? Then in the ADOPT trial, patients, this is mind you initial treatment. So patients were given rosiglitazone or metformin or glyburide, sulfonylurea, and they followed up for 5 years. Now look again, with the sulfonylurea, beta cell function improves so much. Then it begins to come down, agreed. But look at 5 years, it is still above these two lines. And you know rosiglitazone is a thiazolidine, one of the best agents to preserve beta cell. There also, it has given them quite a bit of a race. So I've shown you KPDS, I've shown you great, these are all good quality, long duration trials. I've shown you ADOPT. And the last one is the TOSCA IT trial. Here, sorry, just give me a second. TOSCA IT trial, here patients, the previous one was insulin tablet naive patients. Here the patients were already on metformin. Now you have added either 5-litazone or sulfonylurea. Look at the HbA1c at 5 years, is almost touching each other. So Rudy Holman, I think he was one of the key figures in EKPDS. There is no solid evidence for beta cell exhaustion in the clinical setting over 6 years in the EKPDS. Now anybody, any KOL standing and saying sulfonylurea destroys the beta cell, please cite and ask the speaker, tell me the justification of all these studies then. So next, sulfonylurea can harm the heart. Okay, let us examine. So UKPDS 44-year follow-up. With sulfonylureas, you have got all-cause mortality, MI, microvascular disease, all coming down. How long is the follow-up? 44 years. Again, I come to the GREAT trial, 3-point MACE. Here, liraglutide has the least 3-point MACE. That is, it is the best. Which is second, not insulin, not DPP4, but glimepiride, 3%. Very close to liraglutide. So why are we saying it is detrimental if this is what it shows? Hospitalization due to heart failure, again it is better than the DPP4 inhibitors. Advanced study which I told you, this is a study where intensive glycemic control was achieved with gliclazide MR. Then the composite endpoint of major micro and microvascular events was less than 10%. But here, it's a catch that the main reduction was microvascular, not the macrovascular. So that we have to remember. In the Carolina study, where glimepiride was compared head-to-head with linagliptin, there also you can see all in the center. The 3-point MACE, the 4-point MACE, all in the center. In fact, the heart failure, it seemed to favor the glimepiride a little bit over linagliptin. So where is the evidence that it is detrimental to the heart? I've shown you Carolina, I've shown you Advance. Advance, you know, it is intensive therapy based on gliclazide MR. No worsening, in fact improvement in the combined outcome. So the second case, this patient has an HbA1c of 7, started on prednisolone 20 milligram for whatever reason. You know, there aren't good guidelines for steroid-induced hyperglycemia for non-diabetic and for diabetic patients. One of the best guidelines that you will get is the Joint British Society guidelines. Okay, the last paper which has come out was 2023. So they have clearly said, is the patient known to have diabetes? No. Then gliclazide, because this very closely mimics the profile of the prednisolone. The PP sugar comes down nicely. So this is what they have recommended, and UK hospitals they use it. And those who are have diabetes, if they are not on gliclazide, you start gliclazide. That is the Joint British Society guideline. Of course, if you have got a longer acting steroid like dexamethasone, then you may need additional cover. You can use the sustained release variety. Now I've changed the case to a 74-year-old. Here now we have to worry about hypoglycemia. Yes, we have to get the blood sugar down, it's still high, but we have to worry about hypoglycemia. So which sulfonylurea to choose and why? So hypoglycemia, one of the best areas where you can investigate this is Ramadan. So that will equate to fasting and feasting in the Hindus and Jain, and in CKD, because they are all prone to develop hypoglycemia. So I'll come one by one. Here, little bit of concentration is needed because you need the mechanism of action. So you see here, this is the beta cell. This is the potassium ATP channel. When glucose enters the beta cell, ATP is generated. When ATP is generated, it stops this potassium ATP channel, closes it. When the potassium ATP channel is closed, immediately calcium channel opens and insulin is liberated. So what happens? You have to close this channel, then insulin will come out. But in the heart also you have got this. In the heart, if you close this channel, that is bad. It prevents ischemic reconditioning. It is thought to protect heart during periods of ischemia. So you want a drug to stop here and release insulin, but not work here, okay? Now, this is the comparison of all the sulfonylureas. Now, if you look here carefully, the relative efficacy of SUR1, which is beta cell, as opposed to cardiac cell, which is SUR2, you will find gliclazide, it is 16,000. It is highly specific for beta cell in the pancreas only, having almost no effect on the cardiac. But if you look at the others, glimepiride, glibenclamide is 6.4 and glimepiride is very less specific, 1.35, almost equal. However, I have to, just because I am talking about gliclazide a bit more doesn't mean I will demean glimepiride. I also use glimepiride. So the counter argument is that in the cardiac cell, the potassium ATP channel, there are two places, sarcolemma and mitochondria. So the glimepiride, it blocks the sarcolemma, whereas glibenclamide blocks both mitochondria and sarcolemma. If you block mitochondria, that is bad. That is the argument against this. But overall, gliclazide is very specific. Now look at the active metabolites. So gliclazide and glipizide, they don't have any active metabolites, whereas the glibenclamide has, glimepiride has. Why is it important? Because the active metabolites retain the hypoglycemic potential, retain the ability to further lower the blood sugar. Therefore, this is one of the reasons why gliclazide and glipizide is favored in patients with CKD, because there are no active metabolites. Now, you will find this is one of the articles which suggests that gliclazide seems to have low rates of hypoglycemia and severe hypoglycemia, but you will find some meta-analysis if you are speaking on a glimepiride symposium that it is all the same. So we need head-to-head comparison. So this is collation of all the sulfonylurea head-to-head comparison. So majority is gliclazide versus glibenclamide. You can see here, gliclazide, glibenclamide, gliclazide, glibenclamide. There is only one trial which compares glimepiride with gliclazide. Only one till date. That was done 20 years ago. No other trial. And this trial was actually a very well conducted double-blind trial. So this is the guide study, where about 850 patients were randomized to either gliclazide MR, dose increased every 2 weeks, or glimepiride. Mind you, 20 years ago there were no other drugs. So patients were either on no treatment or on metformin or alpha-glucoside inhibitors. Now you can see here, they were well matched for age, HbA1c, BMI, everything. They were very well matched. Now the aim is, who lowers HbA1c better? Double blind, mind you. Who has less hypoglycemia? So patients who were given as monotherapy and metformin, both were same. So numerically, gliclazide seems to be slightly better, but really, this is statistically, there was no difference. So HbA1c, we will say the same, numerically gliclazide better. Hypoglycemia. So those who are given monotherapy, 50% less hypoglycemia with gliclazide. And those who were combined with metformin, there was 70% drop in the hypoglycemia. So as I said, no other trial has been done till date comparing this. This is the only trial. And I don't comprehend why the gliclazide companies never ever talk about this. I have no idea why not. Now, another group, I told you this patient was 74 years old. So in this same guide study, more than 65 years, percentage of patients having hypoglycemia was almost 3 times less in the gliclazide arm. And those who had CKD, eGFR less than 50, none here. That's not the whole truth. So I'll be lying if I say there's only 2 studies. There are other studies also. In the other studies with here, Hasnan and Mbanya, here DPP-4 inhibitors seem to do better than gliclazide. 6% versus 8.7% and 5.6% versus 7.2% with gliclazide. So it's a balance. So some studies show that gliclazide is same or even slightly better. Other studies show DPP-4 better in Ramadan patients. Now, renal. So the renal bit in the advanced ON trial, which is a continuation of that trial, there was a 46% reduction in end-stage kidney disease. This is, as I said, advanced trial is a trial based on gliclazide MR-induced intensification of diabetes therapy. And KDOQI guideline had said that in patients with CKD, mind you, stage 3, 4, 5 and non-dialysis stage 5, no dose adjustment for glipizide or gliclazide and start conservatively at 1 milligram. I will hasten to add here, the recent KDOQI doesn't have the gliclazide at all. Why not? Because in the United States they don't have gliclazide. But this is just the previous one which suggested no dose, and all the nephrologists are happy if I prescribe gliclazide. They become unhappy if I prescribe glimepiride in patients who are in stage 4 or 5 at least. Now this is the real world data in the JADE. For lack of time, I'll just quickly go through. There are more than 1 lakh patients, real life use, and their S-sulfonylurea use I think is close to 60-65%. And here also, gliclazide use was associated with 19% lower risk of hypoglycemia. But this is an observational study with all its bias. If you have to look at one study head to head, that is the guide. So my last slide, so I'll compare all of these. You need some masala in food. So this is the masala. This is the take home, which one to choose. So efficacy wise, I think glimepiride, gliclazide, glimepiride are the same. Now glipizide, number of studies are less and small numbers, less duration. And glipizide has to be used 3 times a day if you are not using the extended release. So I put a smaller circle, okay? CV effect. So with glimepiride, you have got none of the sulfonylureas have got a dedicated CVOT, mind you. But here you have got the grade and Carolina which you can put, and here you have got the very large study, advanced study, done over a period of several years. Next, hypoglycemia. Here a bigger circle is bad. So glibenclamide has the worst hypoglycemia potential, followed by glimepiride, followed by gliclazide. So Chairperson sir, I got 1 minute. Ramadan, you have got the best evidence amongst the sulfonylureas with gliclazide. Glibenclamide I put the smallest circle, no data with glipizide that I can detect, I can find. Renal failure, again, gliclazide, you have got a bigger circle that is recommended in the KDOQI guideline. Glipizide has almost the same circle as gliclazide, but gliclazide has got a larger volume of data. And steroid-induced hyperglycemia, I think glimepiride and gliclazide I put both larger circles, but in the JP and STS, they have shown gliclazide to be better. So this is the take home in choosing between the sulfonylureas. With that I end. Thank you very much. I've got 1 second.